Like sex with a man, yes. During sex with a woman, no. I think it depends, right? Sex with a person with a penis, yes.
I just assumed that we just got to it a little quickly. I needed some warming up.
In the many events in my life, perhaps, yes.
I actually think that it's very common to have pain during sex, but it is not something that should be accepted as a norm.
Pretty sure it's common because women we aren't taught to complain about pain.
I don't think it's normal, but I think it's okay. I don't think there's any not okay way to have your body to feel a certain way.
So dyspareunia really is a symptom when patients present to us with pain with intercourse. So they can have pain during intercourse or even a soreness or pain post-intercourse. It's all wrapped under one umbrella.
Studies show that anywhere between 3 to 46% of people experience dyspareunia at least once in their life. And the statistic is alarming because of the range that shows. And the reason for that is because dyspareunia is actually a social stigma, and people often don't feel comfortable talking about it. So that's why we're talking about it here. Often, dyspareunia is accompanied with poor body image, difficulty maintaining healthy, intimate partner relationships, and often even times with mental health issues. And the important thing is that pelvic floor PTs are here to help. And there are many reasons why dyspareunia might happen. So here are a few categories. Tight pelvic floor muscles. The pelvic floor muscles are supportive by nature and generally have some amount of activity in them. But studies show that people with dyspareunia have higher activation in these muscles. Dryness. There are a few reasons for dryness, including lack of lubrication, lack of arousal, and lack of prior sexual activity. Some medications, including antihistamines, are also linked to dryness. In postmenopausal women, loss of estrogen can cause thinning vaginal tissue, called vaginal atrophy. This causes burning and itching. Musculoskeletal issues. Simply not being able to sustain a position due to hip tightness or arthritis can also cause dyspareunia. Postpartum issues. Vaginal childbirth is considered a trauma to the pelvis, especially after forceps delivery, episiotomy tears, or other injuries. Dyspareunia may ensue. Psychosocial issues. Dyspareunia is linked to depression, anxiety, sexual abuse, and fear of sexual abuse. Other medical conditions like urinary tract infections, endometriosis, pelvic inflammatory disease, eczema, psoriasis, lichen sclerosis, pudendal nerve damage, interstitial cystitis, pelvic adhesions, retroverted uterus, prolapse, cancer treatment, and surgery can all cause dyspareunia.
I mean, the only exercise I can think of is Kegels. And it's possible that Kegels could have an effect on it. Maybe there's some sort of targeted muscle relaxant.
I've heard meditation, I think, works wonders for kind of getting through moments like that.
Learning how to work those muscles and like sort of pump blood into that area where it's often being like held too tight.
Maybe stretches or of some sort, exercises. There's got to be something. Maybe using toys or something that can help stretch that area or make it less painful. Something along those lines.
For dyspareunia, when people come to see us, they typically have seen a gynecologist because we have doctors, physiatrists, so they've ruled out underlying infection, which is number one. So what we do is we start pelvic floor physical therapy for our patients. And what that means is a combination of internal and external myofascial release. So there is some intravaginal, sometimes intrarectal release, as well as abdominal treatments, visceral mobilization. So we work closely as physiatrists with pelvic floor physical therapists to really kind of reset the muscle spasm and calm down those inflamed nerves that happens with pain with intercourse. That's the first thing we do. And then if the patient hasn't tried that, we would send them and then bring them back in 4 to 6 weeks and see how they did. If they did not improve, then we'll see, sometimes we'll initiate some sort of, if there's entrance pain, a topical. We do a lot of topical creams for entrance pain specifically. It can be lidocaine only, or sometimes we'll do topical baclofen ketamine cream, something topical, and or hormonal, and or we use a lot of, we call it high-al vag cream, so a hyaluronic acid actually that people put on their face. We sometimes put it externally to help increase the tissue blood flow really and make it more plump. So topicals is one common option that we'll do. We also do some suppositories for our patients. If the pelvic floor PT help, but a little bit, but not quite where they need to be. Well, and they're still in spasm, their pelvic floor muscles are still in spasm, we'll give a suppository. And our suppositories commonly have a muscle relaxer in them, either Valium or baclofen, and sometimes we'll combine it with what we call a nerve medication to chill out the nerves. But really what we're trying to do is treat that muscle spasm. So, and then in addition, we quite often with pelvic floor PT, there's a specific protocol that we do at PRM where we do external ultrasound guided hydrodissection nerve blocks and trigger points to the pelvic floor musculature. Really, it's conceptually doing what PT does, similar. We're trying to create space, calm down the inflammation, increase blood flow, and really ultimately reset that spastic muscle. But it's a series, 3 on each side, and really patients go on, see us at 8:30 in the morning to go to their 9:30 meeting. There's no downtime. It's a very tiny needle, so a very basic procedure, but it's seeing us with PT and really conceptually working together to treat that myofascial dysfunction and that nerve dysfunction. So that's what we would do. It's a protocol that we have. And in addition, we have everybody meditating. So we talk a lot about either meditating on your own at home with headspace, calm. Everybody's doing diaphragmatic breathing to really reset the sympathetic parasympathetic nervous system and really down-regulate the upregulated nerves that happens with pain with intercourse. And or we have one-on-one cognitive behavioral therapy that we also offer within our PRM. We have a specialist who only does pain with intercourse, pelvic pain. So that's kind of our approach. It's really treating the muscles, nerves, and the brain with pelvic floor PT.
Some studies suggest that a lifetime prevalence of dyspareunia is 12% in women and 8% in men. Half of all women and more than half of all men report that it was distressing, but most did not seek help.
Maybe because they have told people and people have said, nothing to do. Like I said, have a glass of wine, you'll be fine. Ultrasound's normal, because it almost always is normal, particularly with endometriosis. It's a silent disease. So it's always normal. The MRI is normal, the blood work's normal, the ultrasound's normal, the cultures are normal. So then they're like, must be in my head. But it's not. It's not in your head at all. And that's like what our mission is to validate patients, let them know we have a treatment protocol, we have a plan. We work closely with pelvic floor PT and cognitive behavioral therapy. And it's a non-operative way to really get you having intercourse again and enjoying it.
It can be really hard to talk about these things. I can't imagine if you're going through anything that has to do with painful sex, how difficult it could be to talk to a medical professional about it. But pelvic floor PTs are here to help you. Don't live alone with your pain. Seek help.